Hello, everyone, and welcome back in the Doodle Nurse. If you're new here, my name is Maria, and this channel is dedicated to making complex psychiatric or nursing topics into a simple, engaging, and easy to understand way. Before we begin, I'd like to share a brief disclaimer. This content is intended for educational and informational purposes only. The information presented here is based on current psychiatric nursing concepts and evidence based practice. It's not intended to replace a professional or psychiatric medical advice, diagnosis, or treatment. Please follow your facility protocol and provider orders. If you or someone you know is experiencing symptoms of bipolar disorder or another mental health condition, please seek evaluation from a qualified healthcare professional. If you or someone else is experiencing a mental health emergency or thoughts of self harm, please contact your local emergency services or your local crisis resources immediately. So now let's begin learning about bipolar disorder and understanding the highs and the lows. So you may be asking, what is bipolar disorder? Bipolar disorder is a chronic mood disorder that causes significant changes in a person's mood, energy, activity level, and ability to function. Unlike the ordinary mood changes that everyone experiences, bipolar disorder involves distinct episodes of mania or hypomania and depression. These episodes can last for days, weeks, or even months and often interfere with work, relationships, school, and daily life. Many people mistakenly believe bipolar disorder simply means being happy one moment and then sad the next. That is not accurate. Bipolar disorder involves true mood episodes that meet the specific diagnostic criteria in the DSM-5-TR. Now let's look at the illustration in the center of the slide. The left side represents the high, also known as mania or hypomania. During these episodes, individuals may experience the extremely high energy, elevated confidence, or even grandiosity, racing thoughts, talking too much, more than usual, and feeling like they don't need sleep, increased goal directed activity, and they also have impulsive behaviors such as excessive spending, risky sexual activity, very reckless driving, or poor financial decisions. Although people sometimes describe mania as feeling amazing at first, it can quickly become dangerous because judgment is impaired. In severe manic episodes, patients may even experience psychosis, including the hallucinations or delusions, and hospitalizations may become necessary to maintain safety. Now, let's look at the low, which represents the depression. During depressive episodes, individuals commonly experience the persistent sadness, loss of interest in activities that they once enjoyed. They will have fatigue, low motivation, and also feelings of hopelessness, difficulty concentrating, changes in appetite, sleep disturbances, and feelings of worthlessness. In severe cases, depression may include thoughts of death or suicide. Only depressive episodes often last much longer than manic episodes and frequently have the greatest impact on a person's quality of life. Early recognition matters, so one of the most important messages on this video is that early recognition and treatment improve the outcomes. The sooner bipolar disorder is identified and treated, the better the chances of preventing future mood episodes, reducing hospitalizations, preserving relationships, and improving overall functioning. Therefore, early intervention truly changes lives. Now, there are a few types of bipolar disorder, and let's briefly discuss these three major bipolar disorders. Bipolar 1 is the one manic episode, and bipolar depressive episodes commonly occur, but they are not required to make the diagnosis. Mania in bipolar 1 is severe enough to cause significant impairment, hospitalization, or psychotic symptoms. For the bipolar 2 disorder, this is different because patients experience at least one hypomanic episode and at least one major depressive episode. However, they have never experienced a full manic episode. Many patients with bipolar 2 spend more time struggling with depression than hypomania. For the cyclothymic disorder, this is a milder but chronic form of bipolar. Individuals experience numerous periods of hypomanic symptoms and depressive symptoms over at least 2 years in adults and 1 year in children and adolescents. However, the symptoms never meet the full criteria for hypomania or major depressive disorder. On our nursing pearls, let's discuss what nurses should remember. And as nurses, we should assess more than just the mood. We routinely evaluate mood changes, sleep patterns, the energy level, medication adherence, and the suicide risk. Sleep is especially important because decreased need for sleep is often one of the earliest warning signs that a manic episode may be developing. On medication adherence, w- one of the strongest predictors of long term stability because patients sometimes stop taking medication because they stop feeling better or they begin feeling so much better or they dislike the side effects. And this significantly increases the risk of relapse. Now that we understand what bipolar disorder is, let's take a closer look at the three primary bipolar disorders recognized in the DSM 5-TR: bipolar 1 disorder, and bipolar 2, and the cyclothymic disorder. Although these conditions share similarities, they differ in symptom severity, duration, and diagnostic criteria. Now let's begin with the bipolar 1 disorder. The hallmark here is the feature of having the presence of at least one manic episode. And a manic episode is a period of abnormally elevated, expansive, or irritable mood accompanied by increased energy or activity that lasts at least 1 week unless hospitalization is required sooner. During the mania, individuals may experience inflated self esteem, grandiosity, decreased need for sleep, rapid speech, racing thoughts, distractibility, increased goal directed activity, and risky behaviors. Examples include the excessive spending, impulsive business ventures, reckless driving, or risky sexual behavior. For manic episodes, they can become severe enough to cause significant impairment in social or occupational functioning. Some individuals may require hospitalization to ensure their safety. Psychotic symptoms such as delusions or hallucinations may also occur during the severe manic episodes. An important pearl here is that depressive episodes are common in bipolar 1 disorder, but they are not required for the diagnosis. The presence of a manic episode alone is sufficient. Next is the bipolar 2 disorder, and this requires at least one hypomanic episode and at least one major depressive episode. Hypomania shares many symptoms with mania, including the increased energy, increased confidence, decreased need for sleep, and heightened productivity. However, hypomania is less severe. It lasts at least 4 consecutive days Does not cause marked impairment though, and it does not require hospitalization and does not involve psychosis. Many people with bipolar disorder too, they spend more time experiencing depression than hypomania. In fact, depressive episodes often lead patients to seek treatment because they can significantly affect quality of life, relationships, and work performance. One of the most important distinctions between bipolar 1 and bipolar 2 is that bipolar 2 patients have no history of full manic episode. If mania ever occurs, the diagnosis changes to bipolar 1 disorder. Now, let's talk about cyclothymic disorder, and this is considered a chronic but milder form of bipolar illness. Individuals experience numerous periods of hypomanic symptoms and depressive symptoms, but the symptoms never become severe enough to meet the full criteria for a hypomanic episode or a major depressive episode. For diagnosis, symptoms must be present at least 2 years in adults or 1 year in children and adolescents. Many people describe cyclothymia as living on an emotional roller coaster with frequent ups and downs. While symptoms may seem less severe than bipolar 1 or bipolar 2, they can still significantly affect relationships, work performance, and overall well being. Before moving on, let's review the high heel DSM 5 pearls. Bipolar 1 requires at least one manic episode. Bipolar 2 requires hypomania and major depression. Cyclothymic disorder, it involves chronic mood fluctuations that never meet the full episode criteria. Mania lasts at least 1 week or any duration if hospitalization is required. Hypomania lasts at least 4 consecutive days. Psychotic features indicate the mania and not the hypomania. All bipolar disorders they carry an increased risk of suicide, making a routine suicide assessment very essential. Most importantly, early recognition and treatment can dramatically improve outcomes and helps individual achieve the long-term stability and recovery. Now, let's talk about one of the most important topics in bipolar disorders, and these are the differences between mania and hypomania. This distinction is essential because it helps determine whether a patient meets criteria for bipolar 1 or bipolar 2. At first glance, mania and hypomania, they may appear very similar. Both involved an abnormally elevated expansive or very irritable mood, along with increased energy and increased activity. Patients may seem more confident, more productive, they are very more talkative, and require less sleep. However, the key difference is the severity of the symptoms and the degree of impairment that they cause. Now let's start with the mania. According to the DSM-5 TR, a manic episode lasts at least 1 week unless hospitalization becomes necessary sooner. Mania causes marked impairment in social, occupational, academic, or interpersonal functioning. Individuals experiencing mania, they often struggle to recognize that their behavior has become very problematic, and family members may notice the personality change, impulsive decisions, the reckless behaviors, or the increasingly bizarre beliefs. Hospitalization may be required if the patients become a danger to themselves or others, or they develop psychotic symptoms and are unable to care for their basic needs. Psychotic symptoms such as the hallucinations or delusions, they may occur during mania. And this is an important DSM-5 DR pearl. If psychosis is present during a mood elevation, the episode is classified as mania and not hypomania. Now let's talk about hypomania. This usually lasts at least 4 consecutive days, and this means that it's mostly every day. This includes many of the same symptoms seen in mania. However, the symptoms are less severe and do not cause impairment. Individuals with hypomania, they often continue functioning at work, school, or home. In fact, some patients may feel unusually productive, energetic, creative, or socially engaged. Unlike mania, hospitalization is not required and psychotic symptoms are absent. Let's look at the examples. And for the mania, the individual sleeps only 2 hours per night, and this starts multiple projects, and they make impulsive purchases, they become aggressive, and ultimately requires hospitalization. This level of impairment clearly indicates mania. In the hypomania example, the person becomes more talkative, more productive, but sleeps fewer hours than usual, and still maintain normal functioning at work and at home. And this present more consistent with hypomania. As psychiatric nurses and future providers, one of the most valuable assessment clues is asking about sleep. A decreased need for sleep is one of the hallmark symptoms of both mania and hypomania. Patients may report feeling rested after only a few hours of sleep, which differs from insomnia, where individuals want sleep but cannot sleep. When assessing a patient, ask questions about changes in mood, energy level, activity, impulsive behaviors, spending habits, and their sleep patterns. Collateral information from family members can also be extremely helpful because patients may lack insight into their symptoms. Another important consideration is the suicide risk. Although many people associate suicide risk only with depression, bipolar disorder carries elevated suicide risk throughout the course of their illness, particularly during the depressive episodes and mixed features. The good news is that early recognition and treatment can significantly improve outcomes and reduce the relapse rates. Remember that the most important key takeaway is that mania lasts at least 1 week and causes the impairment, and they may require hospitalization, and they may include psychosis. Hypomania lasts at least 4 consecutive days. It does not cause marked impairment. It does not require hospitalization, and it does not include psychosis. One final DSM-5DR pearl is that psychosis during a mood episode automatically classifies the episode as mania and not hypomania. This distinction is very critical for accurate diagnosis and treatment planning in bipolar disorders. Now that we have reviewed the different bipolar disorders and how they present, let's talk about one of the most important topics in the treatment, and these are the first line mood stabilizers. Mood stabilizers are considered the cornerstone of bipolar disorder management. Their primary goal is to reduce the mood swings, prevent the relapse, decrease the symptom severity, and help patients maintain the long term stability. Without appropriate treatment, bipolar disorder often follows a recurring pattern of manic, hypomanic, and depressive episodes. Mood stabilizers can reduce both the frequency and intensity of these episodes. Now let's start with the most well-known mood stabilizer, and this is the lithium. Lithium is often referred to as the gold standard treatment for bipolar disorder 1, and it has been used successfully in psychiatry for decades and remains one of the most effective medications for preventing manic episodes. One of the lithium's most important benefits is its ability to reduce the suicide risk. Research consistently shows that lithium lowers the suicidal behaviors and completed suicides in patients with bipolar disorder. Because individuals with bipolar disorder have a significant increased lifetime risk of suicide compared to the general population, this benefit makes lithium especially valuable. However, lithium requires careful monitoring because it has a relatively narrow therapeutic range. Therapeutic blood levels typically range between approximately zero point 0.6 to 1.2 milliequivalents per liter, depending on the treatment goals and provider recommendations. Nurses should monitor the lithium levels, kidney functions, thyroid function, and hydration status. Patient education is very essential. Patients should be taught to maintain adequate hydration and avoid dehydration and report the symptoms such as tremors, vomiting, diarrhea, confusion, or difficulty walking, which may indicate lithium toxicity. Next, let's discuss valproate, also known as Depakote. Valproate is highly effective for acute manic episodes and is frequently used when rapid symptom stabilization is needed. It is also commonly prescribed for patients experiencing mixed features, meaning that symptoms of both mania and depression occur simultaneously. Many providers choose valproate when lithium is not appropriate or when patients have difficulty tolerating lithium. Because valproate can affect the liver and the blood cells, monitoring typically includes the liver function test, CBCs, and the serum drug levels when indicated. Patient education should include the recognizing of the symptoms such as unusual bruising, excessive bleeding, abdominal pain, or severe fatigue. Now, let's move to lamotrigine, or commonly known as lamictal. Lamotrigine is unique because it is particularly effective for bipolar depression and maintenance treatment. Unlike lithium or valproate, lamotrigine is generally not considered highly effective for acute manic episodes. Instead, it is often used to prevent the depressive relapse and helps maintain long-term mood stability. One of the most important nursing considerations with lamotrigine is the risk for serious skin rashes or skin reactions, including the Stevens-Johnson syndrome. Although rare, this reaction can be life-threatening. To reduce the risk, lamotrigine must be titrated slowly. Lamotrigine has a low titration of 25 milligrams on the first week and the second week, 50 milligram on week 3 and 4, and 100 on the week 5 and plus. Patients should be instructed to immediately report any new rash, blistering, peeling of the skin, or mucosal lesions. Patient education about the gradual dose increases is critical because rapid titration significantly increases the risk. Finally, let's talk about carbamazepine or the Tegretol. Carbamazepine is considered an alternative mood stabilizer and is often used in treatment-resistant cases or when patients do not respond enough to other medications. It may be beneficial for some patients with acute mania or mixed features. However, carbamazepine has numerous drug interactions because it affects the liver enzymes involved in medication metabolism. Therefore, monitoring the CBCs, liver function tests, electrolytes, and drug levels when indicated. Patients should be educated about symptoms such as fever, sore throat, unusual bruising, severe rashes, or signs of infection. As psychiatric nurses and future psychiatric providers, our responsibilities extend beyond simply administering these medications. We must monitor medication adherence, therapeutic response, side effects, drug interactions, lab results, and patient understanding of their treatment. Many relapses occur when medications are stopped prematurely or when side effects are not addressed appropriately. Providing education and building a therapeutic relationship can significantly improve adherence and their long term outcomes. The key takeaway from this is that mood stabilizers from the foundation of bipolar disorder treatment. Lithium remains the gold standard for bipolar 1 disorder, and valproate is highly effective for acute mania and mixed episodes. Lamotrigine plays an important role in bipolar disorder and the maintenance of the treatment. And carbamazepine serves as an alternative option, particularly in treatment-resistant cases. When combined with psychotherapy, healthy lifestyle habits, and ongoing follow-ups, these medications can dramatically improve functioning and quality of life for individuals living with bipolar disorder. On this screen, we are looking at atypical antipsychotics, also known as second generation antipsychotics. Despite their name, these medications are not used only for psychotic disorders. They are among the most important medications for treating bipolar disorder, particularly during acute mania, bipolar depression, and long term maintenance therapy. One of the biggest advantages of atypical antipsychotics is that many work relatively quickly to stabilize mood. However, each medication has its own strengths, side effect profile, and FDA approved indications. Choosing the right medication depends on the patient's symptoms, medical history, tolerability, and preferences. So now let's briefly review each medication. One is the quetiapine or Seroquel. Quetiapine is one of the most versatile medications for bipolar disorder. It is FDA approved for acute manic episodes and bipolar depression. Maintenance treatment when used alone or even with mood stabilizers. One of its defining characteristics is its sedating effect, making it particularly useful for patients experiencing insomnia or agitation during the mood episodes. However, because of its sedative properties, patients should be educated about drowsiness, orthostatic hypotension, and avoiding driving or operating machinery until they know how the medication affects them. It can also contribute to weight gain and metabolic syndrome, so regular monitoring is very important. Second is lorazepam or Latuda. Lorazepam is unique because it is primarily used for bipolar depression rather than acute mania. Compared with many other atypical antipsychotics, it has lower risk of weight gain, it has less sedation, and has more favorable metabolic profile. An important nursing teaching point here is that Latuda must be taken with at least 350 calories of food to ensure proper absorption. Taking it without food can significantly decrease its effectiveness. Now for olanzapine or Zyprexa. Olanzapine is highly effective for acute mania and maintenance treatment. It is often considered one of the strongest antipsychotics for controlling severe manic symptoms. However, its effectiveness comes with significant metabolic concerns. Patients commonly experience significant weight gain, increased appetite, elevated blood sugar, and elevated cholesterol and triglycerides level. Because of this risk, nurses should monitor weight, circumference, blood glucose, lipid profile. Lifestyle counseling regarding nutrition and exercise should begin early in the treatment. Now for risperidone, or known as Risperdal. Risperidone is very effective for acute mania and maintenance therapy. Compared with some other atypical antipsychotics, risperidone has a higher risk of extrapyramidal symptoms, also known as APS. These include tremors, muscle rigidity, restlessness, slow movements, and dystonia. Nurses should assess patients regularly for involuntary abnormal movements and report symptoms promptly. Risperidone can also increase prolactin levels, which may lead to galactorrhea, amenorrhea, sexual dysfunction, and gynecomastia. Next is the aripiprazole or Abilify. Aripiprazole works differently from many other atypical antipsychotics because it is a partial dopamine D2 receptor agonist and instead of a full antagonist. It is effective for acute mania and maintenance treatment. One major advantage is its lower risk of weight gain and lower metabolic risk. However, because it can be somewhat activating, some patients experience restlessness, anxiety, insomnia, and akathisia. Patients should be monitored for increased agitation after starting therapy. Now, for cariprazine or Vraylar, cariprazine is another partial dopamine agonist. It is FDA approved for acute mania and bipolar depression. Its advantages include the lower weight gain and less sedation than many other atypical antipsychotics. Because cariprazine has a very long half-life, improvements in side effects, it may take several weeks to fully appear, and clinicians should avoid making medication adjustments too quickly. Now on ziprasidone or Geodon. Ziprasidone is effective for acute mania and maintenance treatment. One of its biggest benefits is its relatively low metabolic risk, making it a reasonable option for patients concerned about their weight gain or diabetes. However, there are two important nursing considerations here. First, ziprasidone must be taken with food, ideally at least 500 calories to achieve adequate absorption. Second, it carries a risk of QT interval prolongation, which can increase the risk of potentially serious side arrhythmias. Patients with cardiac disease or those taking other QT prolonging medications may require ECG monitoring because this can cause serious cardiac arrhythmias. Now, for olanzapine and fluoxetine, it's a combination and is commonly named or called as Symbiox. Symbiox combines the olanzapine and it's an atypical antipsychotic, and fluoxetine is an SSRI antidepressant. This combination is FDA approved specifically for bipolar depression. While effective, it carries many of the same metabolic risk as olanzapine alone, including the significant weight gain, sedation, increased risk of diabetes, and elevated cholesterol. Patients should receive ongoing metabolic monitoring throughout their treatment. The nursing takeaway here is that there is no single best atypical antipsychotic for every patient. Medication selection should always consider the whether the patient is experiencing mania or depression, if they have previous medication response, any side effect profile, any medical comorbidities, weight and metabolic concerns, and also their sleep patterns, also patient preferences and medication adherence. As nurses and future psychiatric providers, our role is to educate patients, monitor therapeutic response, assess their possible adverse effects, encourage medication adherence, and collaborate with the disciplinary team to optimize treatment. Ultimately, individualized care helps improve symptom control, reduce relapse, and also enhance quality of life for individuals living with bipolar disorder. This screen focuses on the treatment of bipolar depression, which differs significantly from the treatment of major depressive disorder. One of the most important concepts to remember is that not all antidepressants are safe when used alone in bipolar disorder. Unlike unipolar depression, giving an antidepressant without a mood stabilizer can increase the risk of triggering a manic or hypomanic episode. This phenomenon is known as a treatment emergent mood switch. Because of this risk, treatment guidelines recommend using medications that have proven efficacy for bipolar depression while also helping prevent mood instability. Now, let's review the common treatment options. Quetiapine or Seroquel is one of the first line treatments for bipolar depression. It is FDA approved for depressive episodes in disorder and is also effective for acute mania and maintenance therapy. Many patients benefit from its calming and sedating effects, particularly if they struggle with insomnia or agitation, as we mentioned earlier. However, clinicians should also monitor for excessive sedation, weight gain, and metabolic side effects, including elevated blood glucose and cholesterol. For lorazepam or Latuda, lorazepam is another first-line medication. It's specifically approved for bipolar depression. Compared with many other atypical antipsychotics, it has lower risk of weight gain and metabolic complications. As mentioned earlier, a key nursing teaching point here is that lorazepam or Latuda must be taken with at least 350 calories of food to ensure adequate absorption. Without food, much less medication is absorbed, reducing its effectiveness. For cariprazine or Vraylar, cariprazine is approved for both acute manic episodes and bipolar depression. It acts as a partial dopamine D2 and D3 receptor agonist and is associated with less weight gain and sedation than several other atypical antipsychotics. Because it has long life, rather, sorry, it has a long half-life, patients may not notice the full therapeutic effect for several weeks. So, as future providers, we should educate patients about the importance of continuing treatment, even if improvement is gradual. Now, for lamotrigine or lamictal, it is partially effective for preventing future depressive episodes and is widely used for maintenance treatment in bipolar disorder. Unlike lithium or many antipsychotics, lamotrigine is not very effective for acute mania, but it plays an important role in reducing depressive relapse. One of the most critical nursing responsibilities is educating patients about the rare but potentially life-threatening rash known as Stevens-Johnson syndrome. Patients should immediately report any new rash, blistering, or skin peeling, especially during dose titration. To reduce this risk, lamotrigine must always be started at low dose and increased gradually. Olanzapine plus fluoxetine or the Symbiox. This combination medication contains the atypical antipsychotic olanzapine and the antidepressant SSRI, fluoxetine or Prozac. It is FDA approved specifically for bipolar depression, as we mentioned at the previous screen. Because olanzapine is included, the medication helps reduce the risk of antidepressant induced mania while treating depressive symptoms. However, we future providers should closely monitor patients for significant weight gain, sedation, elevated blood sugar, and lipid abnormalities. One of the important clinical warning here is that one of the most teaching points for bipolar disorder is that antidepressant monotherapy is generally avoided. Using an antidepressant alone without a mood stabilizer or approved atypical antipsychotic may reduce the risk or may increase the risk of mania, hypomania, rapid cycling, and mood instability. If antidepressants are prescribed, they are typically used in combination with a mood stabilizer or another evidence based medication for bipolar disorder. Lithium, as mentioned earlier, remains the gold standard, one of the most effective and well studied treatments for bipolar disorder, and is common considered for mood stabilizer. Lithium is very effective for treating acute mania, preventing future manic episodes, reducing depressive episodes, and for long term maintenance therapy. We have mentioned earlier that monitoring while taking lithium, because it has a narrow therapeutic index, it means that therapeutic dose is close to the toxic dose. So regular laboratory monitoring is very essential. Patients require periodic monitoring of serum lithium levels, their kidney function, including BUN and creatinine, also thyroid function, especially TSH levels. Patients should also maintain adequate hydration and avoid sudden changes in sodium intake because dehydration or sodium depletion can increase lithium levels and lead to toxicity. The nursing takeaway is that treatment of depression should always be individualized. Healthcare providers must consider the patient's current symptoms, history of manic episodes, medical conditions, previous medication response, and side effect profile while selecting therapy. Equally important is that patient education. Nurses should reinforce medication adherence, explain expected benefits and potential side effects, monitor lab values when indicated, and teach patients to recognize early warning signs of relapse or medication toxicity. With careful medication selection, ongoing monitoring, and patient education, individuals with bipolar disorder can achieve long term mood stability, reduce relapse, improve daily functioning, and enhance their overall quality of life. As we conclude this video, it's important to remember that medications are only part of managing bipolar disorder. Long term success comes from combining medication with healthy lifestyle habits, ongoing monitoring, and strong patient education, also including counseling therapy. Lifestyle interventions are not optional. They are an essential part of treatment and can significantly reduce the frequency and severity of mood episodes. Lifestyle treatment is one of the most powerful statements on this video, and sleep is medicine. For individuals living with bipolar disorder, maintaining healthy sleep is just as important as taking prescribed medications. Sleep deprivation can disrupt the brain's natural regulation and mood and is one of the most common triggers for manic episodes. Encouraging patients to establish consistent bedtime and wake up routines can help stabilize their circadian rhythm and also reduce the risk of relapse. Patients benefit from several healthy lifestyle habits. Their consistent sleep schedule, going to bed and waking up at the same time every day, even on weekends, helps regulate the body's internal clock. Healthcare providers, as future psych NPs, we should educate patients to avoid staying up late, rotating work shifts when possible, excessive caffeine late in the day, and screen time before bedtime. Improving sleep hygiene can significantly improve mood stability. Now, for regular exercise, physical activity offers many benefits for patients with bipolar disorder because study shows that exercise can improve mood, reduce anxiety, decrease depressive symptoms, improve sleep quality, and also enhance overall physical health. Even moderate activities such as walking, cycling, or swimming for at least 30 minutes most days of the week, it can make a meaningful difference. Avoiding substance use, alcohol, and recreational drugs can worsen mood symptoms, interfere with their medications, increase impulsive behaviors, and contribute to relapse. Substance use is associated with more frequent hospitalizations, poor medication adherence, increased suicide risk, and worse long term outcomes. Patients should be encouraged to seek treatment for substance use disorders when appropriate. Now, healthy nutrition plays an important role in both physical and mental health. A balanced diet helps reduce the risk of obesity, diabetes, hypertension, and cardiovascular disease, which are the conditions that are already more common in individuals taking certain mood stabilizers and atypical antipsychotics. Patients should also be educated about maintaining adequate hydration, particularly those taking lithium, because dehydration can increase lithium levels and contribute to toxicity. On stress management, because stress is another common trigger for mood episodes. Healthy coping strategies may include mindfulness meditation, deep breathing exercises, yoga, journaling, spending time with supportive family and friends, and most of all, individual psychotherapy or support groups. Teaching patients how to recognize and manage stress early can reduce the likelihood of relapse. Remember, one of the most important clinical pearls is that sleep disruption is one of the strongest triggers for mania. For many patients, several nights of poor sleep may be an early warning sign that a manic episode is developing. Patients and families should be educated to recognize this symptom and seek medical advice promptly. The nursing takeaway is that we nurses and future psych NPs play a critical role throughout every stage of bipolar disorder treatment. One of our first responsibilities is to monitor mood changes. This includes assessing for worsening depression, signs of mania, emotional instability, and changes in daily functioning. We always have to assess sleep patterns because sleep disturbances often occur before mood episodes, and nurses should routinely ask patients, how many hours are you sleeping? Are you having difficulty falling asleep? Do you feel rested? Have your sleep habits changed recently? These simple questions may identify an impending relapse before more severe symptoms develop. Monitor medication adherence because it is one of the leading causes of relapse in bipolar disorder. Patients may stop medications because they feel better, experience side effects, they miss doses, they believe that they no longer need the treatment. Nurses and future psych NPs should educate patients about the importance of continuing medications even during periods of wellness. Now, watch signs for mania because early recognition allows for earlier intervention. Warning signs include the decreased need for sleep, decreased energy, racing thoughts, excessive talking, risk taking behaviors, increased spending, irritability, and grandiosity. Recognizing these symptoms early can prevent hospitalizations. Also, assess suicide risk regularly because it remains the significantly elevated among individuals with bipolar disorder, especially during depressive episodes or mixed features. Routine suicide assessment should evaluate suicidal thoughts, their intent, any plans, have they have previous attempts, any protective factors, and assess to lethal means. Every assessment should be performed with empathy and without judgment. Now, educate patients and families because education empowers patients to become active participants in their care. Teaching should include medication purpose and side effects, importance of adherence, their sleep hygiene, healthy lifestyle habits, early warning signs of relapse, when to contact their healthcare provider, and also available community resources and support symptoms. Family involvement can also improve medication adherence. They can identify early symptoms and provide emotional support. The final message on this video is that of hope. Recovery is possible, and although bipolar disorder is a lifelong condition, many individuals achieve stable, productive, and fulfilling lives through a combination of evidence based treatment, healthy lifestyle habits, strong social support, and consistent follow up care. As nurses and future psych NPs, our role extends beyond prescribing or administering medications. We educate, we advocate, support, and empower patients throughout their recovery journey. Through compassionate, patient centered care and ongoing collaboration, we can help individuals with bipolar disorder manage their symptoms, reduce relapse, and improve their overall quality of life. Thank you for watching this video on the treatment and nursing management of bipolar disorder. I hope it has strengthened your understanding of evidence based care and the important role nurses play in promoting recovery and long term wellness. And once again, this video is for educational purposes only, and it's not intended to replace or substitute medical, psychiatric advice, diagnosis, or treatment. Please always follow your provider orders and facility protocols. Thanks.